Hello, everyone, and welcome to our webinar today. We are here today to discuss hospice billing, technically hospice reimbursement, and some of the regulatory changes that have happened over the last few months that are going to dramatically impact many of you in 2025. My name is Melinda Gabori. I am CEO and co-founder of Healthcare Provider Solutions. We're very happy that you are here with us today. If at any point today you have questions during the content of the or regarding the content of the webinar or hospice reimbursement period, feel free to type those questions into the Q&A box. I have the Q&A box up and we'll be monitoring it throughout the presentation. So please don't hesitate to type your questions in as they come to you. So we're going to start today with the Hospice Final Rule content. And I do have a late entry that I want to share with you so that I don't forget to share it because it is not a part of the presentation, meaning there is no screen for this. Many of you know, especially if you are involved in the billing processes or reimbursement aspect of your organization at all, that quarterly we have been in the past required to file what is called a credit balance report, even if those numbers were zero. CMS issued a memo in late December, and the Medicare Max have now updated their websites and have put it out there that you are no longer required to file a credit balance report quarterly unless you have credit balances that you need to report and money you need to return. So you'll want to make note of that because once a quarter, within 30 days of the end of the quarter, so coming up, that would have been by January 30th, you would have been required to file the fourth quarter credit balance report. Those are no more unless you have an actual credit balance to report. So you'll want to make note of that. Might save you a little time and energy, not too much, but for an organization like us that does the billing for multiple agencies, both home health and hospice, it's been a little laborious in the past. So that is a big deal, a big change, and make sure that you do make note of that. So in the discussion of the final rule itself, we did see a net 2.9% increase in payments for 2025 for hospice, which began October 1st of 2024. In addition, the hospice cap was also updated by that same percentage to now be 34,465.34. Keeping in mind that 2 years ago, final rule, they finalized that the hospice cap for an extended period of time. I don't remember the year that it was supposed to top out, but for years from now, the cap will automatically be updated based on the payment update that occurs in the final rule each year. So just keep that in mind. The HOPE tool, of course, was finalized and it will go into effect, meaning you will begin using the HOPE tool, which we'll talk about a little bit more later in the presentation, October 1st of 2025. New quality measures that were introduced will be implemented no earlier than November 2027. And the CAHPS hospice survey changes, which were multiple ones. They changed some questions on the survey itself. Plus, they are allowing the use of email surveys now and a email that you can send in advance to tell the decedents that the survey is coming. That all goes into effect April of 2025. So not coinciding with your hospice fiscal year. So you'll want to make sure you're paying attention, make sure that your survey vendors are prepared and are utilizing the appropriate survey as April 1st comes about. Okay. The final payments, as you see, again, increased by 2.9%. You see the final payments in the next to last column on your right in bold print. Those are the rates that went into effect October 1st of 2024. And the last column, just for comparison's sake, of what the rates were in 2024 to what they are today. Keeping in mind that these are base rates. The base rates, of course, do have to be adjusted based on the wage index, where you actually treat patients. We're going to talk about each of these level of cares briefly today, to discuss some billing impacts that each of those may bring, and we'll answer any questions that you have about those as we go. Speaking of the wage index tables are updated every year. Pretty much every wage index in the nation has some adjustment. Some could be up, some could be down, but there are adjustments every year. This year was no exception. In addition, CBSA changes were multiple. The CBSA acronym stands for Core Based Statistical Area, basically the county in which you serve patients. And so the CBSA classification, sometimes there are multiple counties within a CBSA. Sometimes the county alone, one county alone, is a CBSA by itself. For example, in the Northeast, most of the states up there have a different CBSA for pretty much every county, while Tennessee, which is where I am, Nashville, Tennessee, and Davidson County is a CBSA area that also includes the 5 contiguous counties around it. So it depends, but regardless, the CBSA is specific to the county or counties that is in that CBSA that you serve patients in. If you serve multiple counties, you may have multiple CBSA codes, and you need to ensure that each service area in which you provide service, you are utilizing the appropriate CBSA. Well, this is not new, so why are we talking about it today? We're talking about it because of the major revamping of CBSA areas that occurred for 2025 implementation. The many counties, over 50 counties, were changed from having a current urban status to rural status, from rural status to urban status. And then there were other counties that received a new CBSA classification and henceforth a new code to be used on your claims. With the CBSA changes, where a county is changed from urban to rural, there could be a drop in wage index that is significant. A couple of years ago, it was finalized for both home health and hospice that there should and could never be a decrease in your wage index of greater than 5% from what it was the year prior. That 5% limit can only be in place if you are utilizing the temporary CBSA code in the year in which it would have been bigger. So if you went from urban to rural this year, you could potentially have had a 10% drop in wage index. That being the case, for the 2025 fiscal year, you would use the assigned temporary CBSA code, which would start with a 50, and that would limit your wage index decrease to a maximum of 5% below what it was the prior year. And then the next year, if there's less than a 5% decrease, you would go back to your traditional CBSA classification. If it were going to be more than 5% again, you would use the temporary CBSA code yet again. So having said all that to say, especially if you're not familiar with the CBSA classifications and exactly how they work, you're going to want to make sure that your EMR system has the appropriate CBSA code, and that you have the appropriate wage index in your system, primarily because of the financial projections and knowing for sure what you're going to receive in the form of payments. Now, having said that, you having an incorrect wage index in your EMR system is not going to impact your billing or how you get paid. But having an incorrect CBSA code in your EMR system would produce an incorrect CBSA code on your claim, which would impact you not getting paid correctly as you bill your claims. So you need to ensure that that is accurate. Some of you may have just said it to yourself. This started October 1st for us because we're hospice. So we should know by now if there's a problem. Well, that's not necessarily true, because if you bill with a valid CBSA code, whether it's your assigned CBSA code or not, you would get paid. You would just get paid inappropriately. So you want to make sure that you have double checked that. Someone has asked before we move on if there was a memo regarding the credit balance reports that I announced at the beginning of the call, and there absolutely is. During the Q&A session at the end, I will try to get that link posted in the chat. But if you go to the Medicare Learning Network portion of the CMS website, you'll find it there. You can also find a note about it on the Palmetto GBA and the CGS website. I have not checked NGS as of yet. Okay, face-to-face encounter requirements for hospice. Nothing new, but we continue to see issues with face-to-face continuously. So I want to make sure everyone is clear about the requirements and the telehealth requirement regarding face-to-face in just a few moments. Obviously, a face-to-face encounter must be done prior to the third benefit period beginning for a patient, keeping in mind that if you are admitting a patient that is going to be in their third benefit period upon admission, a face-to-face encounter needs to be done upon admission, and every benefit period after that. One of the things we see in reimbursement and billing a lot is hospices emailing us or calling us, etc., panicking because they have just discovered that the patient's in a fourth or fifth benefit period when they thought upon admission the patient was a brand new admission, having never been in hospice before. Where did that fail? We're not really sure. But if the patients had ever had a hospice file a notice of election for them, they should have been in the electronic eligibility file when you checked eligibility for that patient. Some of you may say, well, we didn't check eligibility. Well, that's a problem. That's a huge problem because you need to ensure that you are checking eligibility to ensure, of course, that the patient has Medicare Part A, and you need to establish at that point whether the patient is in their third or later benefit period. If there, for some reason, is a roadblock prohibiting you from establishing 100% that the patient is not in their third or later benefit period, then okay. But the problem is so many times agencies, hospices come up with this problem that we are telling everyone, if you do not know 100% that this is their first ever election, you better do a face-to-face encounter. Even if you wind up not needing it, it's better than if you needed it and didn't have it. Because if you needed it and didn't have it, the entire time you care for that patient until you do one is going to be on your dime, and there will be no reimbursement for it whatsoever. So be very, very, very careful in not conducting face-to-faces with admissions without knowing 100% that it was their first election ever. Of course, in recertification periods where the patient is going into their third or greater, you must have conducted that face-to-face encounter. Can be done within 30 days prior to that recertification date and must be done prior to the written CTI or certification of terminal illness being created by the physician. The face-to-face encounter can be conducted by a physician member of your IDG, medical director included, of course, or a nurse practitioner. Keeping in mind that if a nurse practitioner is conducting your face-to-face encounter, the nurse practitioner must be an employee or a volunteer. They cannot be contracted with your hospice. Also keep in mind that that clinical narrative, the clinical findings from the face-to-face encounter must be passed on to the certifying physician. If the certifying physician did not conduct the face-to-face encounter, And in the case of a nurse practitioner conducting the face-to-face, they must sign an attestation that they passed the clinical findings on to the certifying physician so that the certifying physician can create the clinical narrative of the CTI. That CTI clinical narrative must be based on the face-to-face encounter clinical findings. So that leads us again back to the fact that a CTI cannot be created prior to the face-to-face encounter occurring when you're in that third or later benefit period. Now, the telehealth change that has occurred, telehealth came to us for face-to-face encounters back during the COVID-19 public health emergency. And as the public health emergency began to wind up and they began to release us from the waivers, removing the waivers, I should say, they allowed telehealth to be extended for face-to-face encounters through December 31st of 2024. As we approached December, we were trying our hardest to get legislation passed so that telehealth would be extended for face-to-face encounters into 2025. With the signing of the American Relief Act of 2025 at the middle end of December, I think it was December 20th maybe, or December 19th, somewhere in there, they signed the American Relief Act. The American Relief Act included in it that face-to-face encounters via telehealth would now be extended through March 31st of 2025. We are still hoping to get an even farther extension of telehealth being used, especially in the case of face-to-face encounters. But we now are happy that we got it at least through March 31st of 2025. Do note that you are required to use a HIPAA compliant platform during the public health emergency. You are not required to use not required to use a HIPAA compliant platform, but you are required to use a HIPAA compliant platform now since August. And of course, it needs to be documented that telehealth encounter was both audio and video. It cannot be audio only. And of course, that it's a HIPAA compliant system. The physician certification clarification that was included in the Hospice Final Rule was simply to clarify in the language of the condition of participation that a physician member of the hospice interdisciplinary group may review the patient clinical information and certify a patient's terminal illness. And a physician designee may review the patient clinical information and certify the terminal illness if your medical director is unavailable. So there apparently was some confusion with surveyors and hospices that the medical director was required to certify the patient when indeed a physician member of the hospice IDG can do so. The other clarification that was included in the Hospice Final Rule was the notice of election and election statement discrepancy in the use of those two terms. Many of the medical reviewers, SMRCs, UPICs, etc., were sending denial letters to agencies saying that they were denying claims because of issues with their notice of election. That was not true in any stretch of the imagination. The notice of election is what is filed, obviously, in the first 5 days after a patient has elected the hospice benefit. It's gone into effect for billing purposes to notify the Medicare MAC that the patient has elected the hospice benefit. The election statement, however, is the election statement that your patients sign when they elect the hospice benefit. And so these medical review denials that were saying there was an issue with the notice of election actually meant that there was a problem with the election statement, which if you went on to read the denial letters, it would make sense eventually. So anyway, CMS issued in the final rule this clarification and hopefully has gotten through to the medical reviewers to use the term that they really mean instead of using off the chart terms that nobody understands. So, I has to really dig to decipher, I should say. So that's what that clarification was about. I do want to talk through some of the billing situations surrounding the 4 levels of care that are billed in hospice. We're going to start with routine home care. The routine home care level of care, of course, is 97% of the billing that occurs in hospice occurs under the level of care, routine home care. For payment purposes, routine home care has 2 different rates. There is a higher rate that is paid for days 1 through 60. There is a lower rate that is paid for days 61 plus. So for days 1 through 60, you're going to get paid that higher rate, assuming that the patient has not been with another hospice in the previous 60 days. So what does that mean? That means that if a patient's been with a hospice, let's say 45 days, the patient revokes the benefit, and a week later you admit the patient's count for routine home care day payments will start at day 46 with your admission. If that patient revokes the benefit and 3 months later you admit the patient, that's greater than 60 days from when they revoked the benefit from the prior hospice. 3 months from now, you admit that patient, you're going to get to start the counting over again at 1. So you have to have an interruption, for lack of a better term, of hospice care of 60 days or greater in order to start the counting over. Otherwise, you're counting from the last day they were with the previous hospice. Understanding that, regardless of how the days were billed and paid, it still counts as a day. So in other words, if the patient was with another hospice for 45 days and 5 days of that was respite and 5 days of that was GIP, you're still at day 46. So regardless of the service line that was billed for the days they were on hospice, the day still counts in the counting of 60 to 61 plus. And that's what this talks about, the 60-day gap that has to exist in order to start over at the higher rate. Continuous home care, probably one of the most confusing aspects of hospice billing, as far as how it's reimbursed, the requirements for you to even qualify, the patient to even qualify for continuous home care. Continuous home care basically means that the patient is in a period of crisis that needs to be a medical crisis. And in order for them to be maintained in their home or their current place of residence, you're going to be providing at least 8 hours of care in a 24-hour period, beginning and ending at midnight. So a lot of people have controversy over this beginning and ending at midnight situation because of the fact that they just don't get it. And what if they start continuous home care at 10 o'clock at night? They have to start over again at midnight. And the answer is yes, you have to start over again at midnight, because once you cross midnight, you're into a new date of service. And on the claim itself, the same date of service has to have 8 hours or more of care. So today's the 7th. If you started continuous home care at 10 p.m. at midnight 01, it is now January 8th. And so on the claim, anytime after midnight would be 1/8, not 1/7. So you would only have 2 hours of care on 1/7. So that's why it's a midnight to midnight situation. The 8 hours of care provided under continuous can be provided by an RN or LPN for the nursing portion, and then home health or hospice aides, whichever term you want to use there. At least 50% of the time spent must be by a nurse. Can be RNs or LPNs. So if you do have, let's say, 8.5 hours, at least 4 hours and 15 minutes of that time must be done by nurses. Medicare is very specific in the manuals that you cannot write off some of the hospice time in order to make it equal. So in other words, if you had 8.5 hours, and 5 of those hours were an aid, you couldn't fix that. You couldn't fix it anyway because you'd be less than 8 hours. So if you had 10 hours and 6 hours was an aid, and 4 hours was a nurse, you couldn't write off 2 of the 8 hours and not bill it to make it 4 and 4 and a total of 8. That's technically considered fraud. So do make sure that you are following the specific aspects of how you are calculating it, and make sure that you get that it is that the patient must be in considered to be in a medical crisis situation. And why am I explaining that in more detail? Again, because of the reality that one of the examples that they use in the Medicare manuals um, talks about a place where a patient is having a medical crisis, but then their only caregiver, their elderly spouse, says they can no longer take care of the patient. You're going to have to do something. And that's called collapse of family structure. And so CMS is very specific to the fact that a collapse of family structure cannot alone be considered continuous home care. The patient has to be in a medical crisis requiring nursing and aid services in order to maintain them in their residence. So when they're calculating the continuous home care hours to determine what your payment should look like, they're using the units that are represented on your claim. So when you look at the details of your claim and you see those nursing visits and you see those aid visits, when you look in the unit column on the claim, if that unit is 1, that means your clinician spent less than 23 minutes in that patient's home. However, if you have 4 units, for example, it's going to be calculated as an hour. And so if your units are not being appropriately reflected on the claim, then you'd never get paid for continuous home care, because having even 8 visits, 1 each, is only going to be 23 minutes for each one, and you're not going to get to 8 hours. And so you need to ensure that your units are reflective of 15-minute increments of time, and that they're being rounded to the nearest increment based on the CMS rounding method, and that it is appropriately reporting those and not just reporting 1 as a visit, but the actual units of time. Hopefully that makes sense. Continuous home care can only be provided in a place of residence. As you see, a private residence, an assisted living facility, a long-term care or skilled nursing facility. CHC or continuous home care may not be provided in an acute care hospital, skilled nursing facility where the patient is receiving skilled care, or an inpatient hospice facility. So any of those acute facilities that you see at the bottom are providing skilled nursing care ongoing to the patient, and therefore the patient would not qualify for continuous home care. Can only be billed in residential situations. So this is the payment amount, or the amount of payment for CHC, is determined based on the number of hours in the 15-minute increments of time on your claim, as we said earlier. Making sure that you have to have a combination of 32 or more units. When I say a combination, that means the units for nursing as well as the units for the aides. They have to they have to be 32 hours, or 32 units, excuse me, or exceed 32 units in combination, all on the same date of service. And again, only nursing time and aid time counts. So we have a couple of questions. One asked if I could go back to the slide before continuous. It was simply, that slide was simply finishing up the routine home care thoughts, that the patient had to have a 60-day interruption of care in order to start the counting over again at 60. And you can see that slide in the handouts. The next question, when a patient transfers from one hospice to another, both hospices can bill for the day of transfer. How does that affect the routine high or routine low timing for reimbursement? Does the day of transfer count as two routine high days? So my thought is, and I don't know this answer absolutely positively without question, so I'm just going to say that up front, but it only makes sense that it would count one day for the previous, one day for the new. And so if the first one on the 20th day transferred the patient, that would be day 20 in the count. Your day one that you get paid for would be day 21. Only thing that makes sense to me, but again, don't have that in concrete regulation I could show you. Inpatient respite care, respite, please see the second bullet and read it in detail. Respite care should be used on a short-term, occasional basis when necessary to relieve the caregiver. We had a hospice ask one time if they could go ahead and put respite on their care plan because they were going to do it the second week of every month. That's not okay. The respite line of service is there for short term, occasionally to be used when the patient absolutely has to have relief from their caregiver situation. So please be thoughtful of that, mindful of that. Respite is payable for up to 5 consecutive days. Days beyond 5 would be billed at the routine home care rate, meaning if the patient were admitted to a facility under respite, after paying for respite for 5 days, the next days plus would be paid at the routine home care rate. Many times we have been asked, can we simply not bill respite for day 6 and then bill 5 more days of respite? The answer is Medicare has in the Medicare claims processing or Medicare benefit policy manual specifically that example saying that it is not okay for you to do that. So do note that you can have more than one respite stay in a billing period, but I would advise you strongly against trying to bill 5 days, skipping a day, and billing 5 more days. The day of admission that you admit a patient to respite care is billed and paid as a respite day. The day of discharge is billed as routine home care. So if you were going to get your entire 5 days paid at respite, the patient would need to go in, for example, on Monday and be discharged on Saturday. So Monday through Friday would be paid at respite. Saturday, when discharged home, would be routine. And if you discharge the patient on Friday home, you would only get paid 4 days of respite. So do keep that in mind. I actually have an example of that on the next screen. Patient is in the inpatient respite level of care 7-1 to 7-5, went back to the routine level of care in their private residence on 7-5. So you would actually get paid respite for 7-1 through 7-4. If the patient was in the inpatient respite level of care from 7-1 to 7-8, patient goes home on 7-8, then respite would be paid 7-1 through 7-5. Hopefully that makes sense to everyone. The general inpatient level of care, or GIP, probably one of the least billed lines of services. It and continuous are probably the least two levels of care. The two levels of care, these two levels of care plus respite, actually, all three of them together make up only 3% of total hospice reimbursement in a year. So it's a very small piece of the puzzle, yet GIP down codes in medical review is one of the top 5 reasons for denial. So if you're admitting a patient to GIP, please ensure that you have details in the documentation to support why the patient need to be admitted to a facility having 24-hour access to an RN coverage in order to control whatever symptom is out of control at home and can't be controlled at home. The day the patient goes to GIP is billed and reimbursed as a GIP day. The day they discharge home is routine home care. If the patient dies in GIP, the date of death is billed and paid as GIP. GIP can only be provided in one of the following three settings: a hospice inpatient unit, a certified hospital, or a Medicare certified skilled nursing facility where the patient is in a bed that would have access to 24-hour RN coverage. Only these three levels of facilities, because the patient requires that 24-hour access to RNs. A question about respite. Can you have respite in the same facility they consider to have routine home care? I'm not really sure how to interpret that question. A patient is in, if the patient is moved to respite in a hospital, then and they're there 7 days, the last 2 days are going to be reimbursed at routine home care. The first 5 days are going to be paid at respite. If that didn't answer the question, you'll need to re-enter it. The service intensity add-on doesn't get talked about as much as we used to talk about it. The service intensity add-on is paid to the patient or paid to the agency, the hospice, for services provided to the patient in the last 7 days of life. This service intensity add-on is provided for visits for a minimum of 15 minutes and a maximum of 4 hours per day, is combined for both nursing time as well as social worker visit time. It does not include social worker phone calls. Even though social worker phone calls go on the claim, those social worker phone calls are not included in the SIA payment in the last 7 days of life. Also note that any post-mortem visits are also not included in the SIA calculation. So if your nurse goes into a patient's home at 6 p.m. and pronounces the patient, once the patient is pronounced at 6 p.m., anytime after 6 p.m. that the clinician or any other clinician remains in the home or provides services to the patient or family, is considered post-mortem, but after the time of death, and would require a PM modifier on the claim. Anytime that is noted with a PM modifier is not included in the service intensity add-on. Also note that the most frequent issue hospices experience with the service intensity add-on is when a patient dies anytime in the first 6 days of a calendar month. Because this is covered by the last 7 days of life, and we have to bill by calendar month. So if the patient dies, for example, on January 4th, then the 4 days in January are included, but there's 3 days in December that should also be considered. So you'll want to monitor and make sure that they are going back and reopening your prior months when the person dies in those first few days of the calendar month, to ensure that you're getting the full service intensity add-on that you should be paid. Okay. Let's see. We have a couple of questions. Patient in an inpatient facility, they change their location of care to routine home care, then they change it to respite. Not really sure what we're saying here. You might want to email me later so we can make sure I can clearly respond to that question. The service intensity add-on applies, does it apply to routine home care in an inpatient hospice facility? If the patient is receiving the routine level of care in those last 7 days, you should be paid the service intensity add-on. The routine level of care can be provided in any location of care. So yes, should be the answer to your question. Okay. The CAHPS hospice survey changes, as I stated earlier, are going to begin April 2025. I almost said December. April of 2025 with April 2025 decedents. As briefly recapped earlier, they are going to allow email now for the hospice survey. You will be able to also send a pre-notification letter up to 1 week prior to when the surveys are going to be distributed. So basically saying a survey is going to be coming in the next week. Please make sure to respond. They are extending the response time from 42 days to 49 days. So they will have 49 days to complete the survey and respond. They have removed some items and they have added some new outcome measures that will be the result of the hospice survey information. The public reporting for these new changes, we will not actually see until we get into 2028, believe it or not. They will start collecting the data from the new survey, and this is for the CAHPS survey measures only. But it will not be seen, the results of these changes will not be seen until February of 2028's refresh, which will include scores from the second quarter 2025 through the first quarter of 2027. So it's really frustrating, to be honest, that when you have a situation where you're trying to gauge how you're doing with new aspects of changes. This happens in multiple arenas, whether it's outcome measures or the value-based purchasing situation in home health, but you're not getting the data needed to follow up and make sure that you're on the right course. Well, this is a perfect example of that. You're going to start using the new forms, et cetera, in 2025, and you're not really going to see it unless you have software or a system that is monitoring it for you real time. And it would have to be your CAHPS vendor in order to see that. You're not going to see the fruits of the changes until many, many months down the road. During the transition time, the star ratings are for the hospice surveys are going to continue to be based on 7 measures. Once the transition has occurred and we get into 2028, the star rating will be based on 9 measures, which include the changes that have been implemented. Okay, we have a couple of questions. Can you admit a patient directly into respite if there's a valid reason for caregiver issue breakdown during the admission? So admit directly into IP respite due to caregiver needing time to arrange a few things to transition the patient's home. Usually this patient's in the hospital and ultimately goes home. I'm not going to tell you that you can't do it. Would probably be a little concerned if they were straight up in respite in the beginning, especially since the patient could be admitted in any location under the routine level of care. So I would think about that a little bit harder before I admitted them under technically respite, when there is the option to admit them being in a facility and eventually going home, admitting them under routine home care. So with a hospital, it might be a little different than if they were in a nursing facility. I'd be careful. If an MD verbally certifies a patient eligible for hospice services, does he or she have to complete the CTI, or can another team associate medical director, that should say complete the CTI, I'm pretty sure. So we have had this debate recently. If a medical director gives you a verbal certification for the patient, that clarification we just saw in the COPs earlier says that a physician designee by the medical director can certify the patient. So I am saying to you that if the medical director of your hospice gives you a verbal certification of a patient, that I believe it to be fully acceptable, especially with that recent clarification in the Hospice Final Rule, for a physician designee of the IDG of your hospice be able to complete and sign the certification. Okay, the Hope tool. We have been waiting for this thing for years and years and years and years and years. It actually started out with a completely different name. It was a completely different form. It actually got to beta testing and then it was trashed. And then they started over. And now we have the Hope. The Hope has been issued in draft form, now final form, I believe, and is going to go or be implemented fully October 1st of 2025. The Hope will fully replace the HIS. So HIS will no longer exist. The Hope will now take its place. You will collect data related to demographics, pain and symptom management, symptom impact, skin conditions, medications, and imminence of death. When the first tool that was scrapped completely was created and even got to beta testing, it was going to be more of a comprehensive assessment of the patient, much more so than what it is going to be now. With the Hope, it's going to fully replace the HIS in all aspects. So you won't do the HIS anymore. You will be required to submit 90% of your Hope records within 30 days of the event or the completion date, whichever is applicable to the specific Hope tool being completed. With that 90% compliance and coupled with your compliance with the CAHPS hospice survey, you would not be subject to a payment reduction with the annual payment update. So if you are non-compliant with 90% of the HIS or Hope soon to be being transmitted timely, or you're non-compliant with the CAHPS hospice surveys, or you're non-compliant with both, you will receive a 4% payment reduction in future years. Now, the thing to keep in mind here is that the HIS, the Hope, and the CAHPS surveys are all on a calendar year, while the annual payment update is on a fiscal year. So the hospice fiscal year, as you all know, starts on October 1st and ends on September 30th. The calendar year is used for the calculation of the measures, which obviously is January to December of each of those years. So in order for you to be compliant for the current year, for 2024, the calendar year we already passed, your HIS would had to have been transmitted 90% of them within the 30-day requirement at the date they were completed. And if you follow that chart over to the right, the CAHPS surveys, you had to be compliant in calendar year 2023. If you were compliant for both of those, then you're good to go for 2026, which would begin payments October 1st of 2025. As we move to the next year, calendar year 2025, for the first 9 months, January through September, for the first 9 months of 2025, that's going to include HIS data, 90% transmitted timely. October 1st through December 31st of 2025 will be the Hope, and its transmission at least 90% timely. For 2024, which is already passed, if you were compliant with the CAHPS hospice survey, that in combination with current year compliance will keep you out of problems with the annual payment update for 2027. If you have any problem with that, make sure you let us know. Someone's asked a question about the Hope. My sense of the new Hope questions, are they worded in a less confusing way than the HIS? I think they are. I think they're pretty self-explanatory in monitoring the patient's symptoms, pain, etc. I'm not going to get into the hospice too deep. I mean, the Hope tool too deep today. Obviously, we have some webinars coming up that one of our hospice nursing specialists will be teaching the Hope tool and the nitty gritty details of the Hope tool, and how it has to be completed and the compliance of when you have to complete follow up visits, etc. So you're going to want to tune into that education if you have not already got Hope tool education scheduled. And but I do feel like it is going to be better for everyone concerned. The struggle is going to be that the HIS didn't necessarily have to be completed by the clinician in the home, where this Hope, the questions for the Hope, are going to need to be completed by your field staff clinicians. Okay, moving on to the special focus program. While this is not a direct billing impact, billing does directly impact the calculation for the special focus program. And so the special focus program, in case you haven't heard, is basically a program that has been implemented to try and exclude, honestly, bad players in the hospice program. The problem is many have an issue with how the calculation is made, what the data is from the calculation, and struggle to believe that it's fully accurate in the way that some of the hospices have scored. Having said that, if you haven't seen it yet, the 50 hospices that had the worst scoring have been published, and is on the CMS Special Focus Program website, for you to download and open, and you can see all 50 hospices that will be targeted for the Special Focus Program next year. Now, this Special Focus Program includes that for 18-month period of time, these hospices will receive a survey as if it were a Medicare certification survey every 6 months. At the end of this 18-month cycle, if not before, the hospice will either be terminated from the Medicare program, or they will graduate from the special focus program, meaning they will have successfully passed these surveys, and not be eliminated from the Medicare program. It says on the screen, and I apologize for that, state agencies will be conducting the surveys. That is not true. That is initially what they were said was going to happen, but they did change that. It is now a third-party company that CMS has hired to conduct these surveys. So it is not your state survey office. The accreditation bodies we've known from the beginning would not be able to do these surveys, meaning CHAP, ACHC, and JCO. They are not allowed to conduct these audits, but they have hired a third-party survey company to do this. During this special focus program, hospices could be subject to enforcement remedies. If the hospice has recently received condition level deficiencies, et cetera, that cause them to have to implement enforcement remedies, those enforcement remedies would still be active and still take place even while they go through this special focus program. And more could be added as a result of the special focus program. The surveys, to get to the special focus program, the calculation for determining if you're going to be targeted, or if you're going to be surveyed, include condition level deficiencies. They're looking at the last 3 consecutive years. If you had any condition level deficiencies, you're likely going to be very high on the totem pole for being in this pool of hospices in the future. The survey reports will tell you specifically that it's a condition level deficiency, which I'm sure all of you or most of you are aware of. Some of you may have never had one and not really sure what that means, but for a condition level deficiency, you have to file an immediate corrective action plan, and have 10 days or so, the surveyor comes back to ensure that the corrective action has been implemented. Complaints with substantiated allegations, which means someone has filed a complaint against your hospice in the last 3 consecutive years. And the surveyor has come back to your office to follow up on that allegation, and that allegation proves to be real, proves to be true. An example, a hospice that someone reported, I think it was a patient's family member reported that the hospice never treated a wound that was on the patient, and it was an extensive, painful wound situation. And sure enough, the surveyor shows up, reviews the charts to find nothing to support that that hospice had ever touched a wound on that patient, or even that the patient had a wound. So those are complaints that are definitely substantiated, and that became an actual condition level deficiency, to be honest. The in addition to condition level deficiencies and substantiated complaints or allegations, they are also looking at your Hospice Care Index and your CAHPS hospice survey data. So when we look at the Hospice Care Index, this is huge. Um, you can get a maximum of 10 points in this calculation. Probably the average hospice is 7 to 10 points. I know of a couple that have drastically lower numbers than that wound up in the special focus program because of that. And so you need to truly look at your hospice care index and pay attention to the information and how the calculation is being made. And I want to share these 10 with you now. Please hear me clearly. I'm really focusing on this today because of the fact that this hospice care index information comes directly from your claims. It doesn't come from anywhere else, not from the HIS, not from anything else that you could submit, cost reports, etc. It comes solely and completely from your monthly claims that you file for payment. So the first one, the percentage of CHC or GIP level of care days reflected on the Medicare claims during the episode needs to be greater than 0 in order for you to get a point. So if you have provided no CHC or GIP whatsoever, you're going to lose a point. Gaps in nursing visits. This is huge. Number of Medicare elections that had gaps in nursing visits greater than 7 days within a 30-day period. So on your monthly claim, you have a nursing visit on the 1st, and your next nursing visit is not until the 10th. That's a 9-day gap, and technically an 8-day gap, because the 1st day and the 10th day don't count. So an 8-day gap with no nursing visits whatsoever occurring, you're going to go into the negative of this calculation. You have to have less than 90% gaps in nursing visits. Number of Medicare elections that had gaps in nursing visits greater than 7 days needs to be less than 90% of your claims had gaps in nursing visits of greater than 7 days. So seems like a pretty easy feat, right? But it depends. You need to monitor how you're scheduling nursing visits. If you're scheduling nursing visit once a month, then you're done. You're going to get 0 points for this calculation, and I'm surprised you haven't already been in extensive medical review if that were the case. Early live discharges, the percentage of early live discharges within 7 days of admission compared to other hospice providers needs to be less than 90%. Late live discharges, percentage of live discharges on or after 180 days from the hospice admission compared to other providers needs to be less than 90%. The percentage of live discharges from hospices followed by hospitalization and subsequent hospice readmission needs to be less than 90%. Now, the live discharges, please be aware that that counts all live discharges. So that counts revocations, that counts being discharged no longer terminally ill. Any live discharge is going to count. So you do need to make sure that you are monitoring that, and that you are looking at potentially, if live discharges are happening at huge percentages in your organization, Are we looking at these patients correctly when admitting them? Should they have been admitted to begin with? Someone's asked the question for the gaps in nursing visits. Do LPN visits count, or is it RNs only? It is nursing visits, so LPN visits would count. Burdensome transitions, the percentage of live discharges from hospice followed by hospitalization with the patient dying in the hospital. Per beneficiary Medicare spending compared to other hospice providers calculated by the total number of payments Medicare paid to hospice providers divided by the total number of hospice beneficiaries served. Meaning you're looking at the total Medicare payments divided by unique beneficiaries to get Medicare spending calculation. Nursing charge minutes per routine home care day. Average skilled nursing minutes per routine home care day compared to other providers needs to be greater than 10%. So when we talk about the skilled nursing care minutes per routine home care day, we go back to where do they get the minutes that you spend in the home? The only place for them to get those minutes is in the unit column of your hospice claims. So if your hospice claims have one in the units, again, it's going to show that your average visit is 22 minutes a visit. You need to ensure that the units are being appropriately reported. Skilled nursing minutes on weekends. So skilled nursing minutes on weekends, Saturdays and Sundays out of all skilled nursing visits during routine service days needs to be greater than 10%. So they're monitoring weekends as well as Monday through Friday. And again, minutes. Only place for them to get minutes is the increments of time that are reported on the claim. And then visits near death, the number of visits near death reflected on the Medicare claims compared to other hospice providers, the percentage of beneficiaries receiving at least one visit by a skilled nurse or a social worker during the last 3 days of the patient's life needs to be greater than 10%. A visit on the date of death, the date prior to the date of death, or the 2 days prior to the date of death is what they're counting. So they gave you that example just to show you what the last 3 days means. So on the date of death and the 2 days prior to the date of death are the 3 days that they're counting here. Obviously, we never know for sure when a patient's going to die, right? But close monitoring of patients' conditions and listening to family members, caregivers, etc., are going to get us closer to knowing how close we are to those last 3 days of life. Graduating or being terminated. So if you're involved in this special focus program and you have no condition level deficiency cited or no immediate jeopardy citations from a complaint for any 2-month to 6-month surveys, and you have no pending complaints, or you have returned to substantially all compliance, you will be removed from the surveys, from the special focus program. So in other words, if they come and do a survey, you get no condition level deficiencies, you have no current outstanding complaints, then basically you've passed that survey. The second one happens 6 months later. If you pass that one as well, you technically could be off the special focus program in 6 to 12 months, right? If they do these 2 surveys within 6 months of each other. However, if you have a condition level deficiency or a complaint that's being triaged as immediate jeopardy or condition level in any of those 2 surveys, you will have to do a third one. And then if you have something occur in that range, in that last one, you could be terminated from the program. So the termination, you see, fails 2 surveys having any condition level deficiencies on the survey or a pending complaint that's been triaged as immediate jeopardy or condition level. So you could pass the first one with flying colors, have a condition level deficiency in the second one, have a condition level deficiency in the third one, and you'd be out of the Medicare program. So if you get selected for this review, you need to be very, very, very meticulous about preparing for that oncoming first survey to ensure that you are good to go with no condition level deficiencies in your near future. and no complaints that have been filed, and if they have, can be substantiated. The provisional period of enhanced oversight has been going on for quite some time. They have expanded this to basically include any new Medicare provider of hospice services or any change of ownership pretty much in any place in the country, focused primarily in the beginning on 4 specific states. They are now looking at, or they did expand this to include post payment reviews or even prepayment reviews just randomly being done on hospices throughout the country, but ones that more specifically are new providers or have had change of ownership. Understanding that the new change of ownership is inclusive of 100% change of ownership or substantial change of ownership, which could be 50% or greater of the ownership changing. There are exceptions to the ownership change situation. For example, a hospice that's owned by one single individual and that individual dies, that change of ownership would not be counted in this enhanced oversight. So we get questions about what this looks like. So if a new provider, I can tell you for sure, we've worked with a couple, two that were new Medicare providers, and one that was a change of ownership. A hospice bought out another hospice. And in both cases, they pulled several charts once the billing began under the new ownership or the newly certified agency. 17 charts in one case, I think it was 19 in another case, and 12 in another case. So there's no specific number of charts that they're going to pull. One had the change in ownership and was a brand new, was a 100% new owner of a hospice that was already in place, passed with flying colors, had no denials at all, and they took them off and they moved on. A couple of the brand new Medicare certified agencies, one had 18 charts or 19, I think it was, charts pulled, and had denials on like 12 of those, so they had more charts pulled. And the one that had 16, I think it was, only had a couple of denials, appealed those, and then they were able to move on as well. So the scrutiny with hospice right now is off the charts. Whether it be the special focus program, the provisional period of enhanced oversight, UPIC audits, SMRC audits, etc., and all because of some bad players. And obviously, we all know that we're not all bad players, right? But we have bad players, and the ones that aren't are paying for it, to be honest. So we have a few minutes left from what we originally scheduled, and have time for some additional questions. If you have questions out there, I'm going to see if I can get my hands on the link that was requested earlier while we wait to see if there's any additional questions. The slides, someone's asking if the slides will be sent via email. If you registered, you should have received an email with the handouts yesterday. And once the recording is ready to be published, there will be another email saying that the recording is ready and the handouts will be linked there. Also, in the chat on your Zoom screen now, on the chat, there is the link to the handout. And I just posted in the chat the link to the CMS memo regarding the change with the quarterly credit balance report. So for the one that asked for that earlier. Okay. I don't see any additional questions. Thank you, Stacy. Stacy put in the Q&A box the link to the Palmetto notification, but I gave you the actual CMS Medicare Learning Network article in the chat. I got the Palmetto notification. It made me nervous because sometimes the Medicare Max jump the gun and make decisions that they can't make on their own. And so I had to wait till I got the CMS memo found to put that out there. That's why it wasn't in your actual presentation today. I don't see any additional questions, so I want to thank you all for participating today. We are really thrilled to have you here. We have a polling question I forgot to mention a second ago. If you want to take time to respond to that for us, we are here, have been in business for 24 years. For those of you who don't know HPS, we have services across the spectrum, including home health, hospice. We do not only billing and collections, we also provide coding services to home health and hospice with a full US based coding team, as well as clinical consulting. We have a team of clinical clinicians that work for both home, have worked for both home health and hospice, have been with us for years, and assist with ADR reviews, UPIC audits, SMRC audits. And I'm already working with a hospice that has been selected for the special focus program. So we are here to assist in any way possible. Please don't hesitate to reach out if you need assistance from us in any way. Our Alliance membership, which is a small fee annually, you're able to participate in each and every monthly webinar that we provide. Our webinars are taught for both home health and hospice. Typically, the months alternate between home health and hospice, and are taught by myself and 3 other consultants that work for us. So thank you so much again for joining us today. We look forward to being with you again in future educational opportunities, and we will give you back a few more minutes in your day. Have a fabulous week, and again, let us know if we can assist in any way.